divided first into certain families. So we have Oncoviridae family, which tells me oncology or cancers would be caused, and that is caused by HTLV1 and 2. Then we have the next one, that is Lentiviridae, which of course is going to have HIV1 and 2. And I'll first start with the more important, that is HIV. Now, when we talk about this, we all know that this is an RNA virus, but it has to come and integrate with our DNA. So it has to change from RNA to DNA. And that process would be known as reverse transcription. So this requires a reverse transcriptase. Now, prior to this, the only other virus where we have studied where a reverse transcriptase would be present other than this family would be the hepatitis B virus, because that has a partially double-stranded DNA and the pathogenesis requires a reverse transcriptase. Coming back to HIV, this is a 100 to 120 nanometer sized virus, and like all other RNA viruses, it is going to be unsegmented. But what makes it distinct is that usually the RNA viruses have one copy of RNA, but this is the only virus RNA family which has two copies. In fact, I always told you that today onwards you would never write it as retrovirus but ret2 virus, which would remind you that it has two copies of RNA in it. Now, usually I don't teach this to you for every organism, but when it's HIV, it has to be a little more specific. So please note, this can be killed by what all or inactivated by what all. So first, in terms of physical methods, it can be inactivated by heat. Please note that HIV is a thermolabile organism, so it can be inactivated by heat. It is said that 60 degrees for 10 minutes can kill it, and if you increase the temperature to let's say 100 degrees, then all that it requires are a few seconds only. So it is going to be killed by heat. What about the chemicals which are often used in the hospital setups? Yes, it can be inactivated by them also, and again, I don't make you learn individual chemicals, but it's HIV, so you have to. So please note, hydrogen peroxide 0.3% can inactivate it, glutaraldehyde 2% can inactivate it, and so can 50% ethanol or alcohol. So this is chemical disinfection as well as physical disinfection, which can take care of HIV. Now let's go on to what is the grouping like. So when I talk about the serotyping of HIV, that is based on the envelope antigen or the envelope protein, and I will show you in a while the structure of HIV, and it has some proteins on its surface called envelope proteins. When they have differences, that is when HIV will become of two types, that is HIV 1 and 2. So in simple words, can I say that there are two serotypes, 1 and 2, out of which the more virulent one is going to be HIV 1, and that is what is prevalent in India. Further, this is going to have 4 groups. What are those 4 groups? They are going in the order of alphabetical order, that is M, N, O, P. And common sense, that M being the first one, that is the most common that you find. So now you've understood that there are serotyping, that is going to be HIV 1 and 2, serotype 1 and 2. In that serotype, there are further groups. So it is group M. Let's assume I'm talking about India. So in India, HIV 1 serotype is most common. In that, the group number M is most common. And amongst the groups, this M group is further made to undergo certain subtyping. Only for the M group, there is subtyping which goes from A to K, and now you know this HIV has started making recombinant forms. Like if it's A, B, C, D, E all the way up till K, now HIV has started making something called circulating recombinant forms or CRF, where two subtypes are coming together, like A and E are present together, so that's a recombinant form. But out of these, what is most commonly seen in India is the subtype C. Most common in India is subtype C, and most common in the world is subtype B. So if I just had to ask you the status of India over here, and let's write it down so that we don't forget it, which is the serotype which is going to be most common in India, it is going to be HIV 1. Amongst that, which is the group which is going to be most common in India is group M, and thereafter amongst group M, the subtype which is more common in India is going to be subtype C. So HIV 1, group M, subtype C is how you define it. Now let's go on to the structure. As I said, it's a 100-120 nanometer in size virus, and if I look at the structure, I can very well visualize this is the only virus which is going to have 2 copies of RNA, and no other one's going to show that. So now I need to know the genes. There are 2 types of genes. One is known as the structural genes and the structural proteins, and the other are the non-structural proteins. Let's split it into 2 slides. The first one is going to be that, again, first thing that I will spot it with the help of those 2 copies of RNA, and here I have it. I'm teaching you the structural genes or the structural proteins, and it's pretty much similar for HIV 1 and 2, although we always teach you from HIV 1 point of view, but where the difference will come, I'll tell you. Till then, it's all going to be the same. So first protein that I see is obviously on the surface, the envelope that is there. I can see there is something projecting out, and then there is something going through and through the membrane. This gene is known as the ENV gene, where obviously ENV will stand for envelope, and this entire envelope thing is known as GP160. And out of this, I can see 2 parts. One is projecting out and one is transmembrane. The one that is projecting projecting out on the upper part is GP120, and the one that is going through and through the membrane is GP41. I mean, if you add them up, you are roughly coming up to a 160, right? So there are 3 proteins that it makes up. The full thing is known as GP160. If you split it, the one on the top, the head, is GP120, and the transmembrane portion is going to be GP41. That is what the ENV gene makes. Now I go on to that, what are the other molecules? You must have heard that in case of a needle stick injury or a needle prick, P24 testing is done. So what is that P24 testing? That is going to be made by the GAG gene. So if you look at the GAG gene, it is making all the P molecules like 6 and 7, then 17 and 24, out of which you must be knowing that this 24 is the one that is going to be present in the capsid. You don't have to know the names of all, but you must know about 24 because that is where the testing is done. So know in an order 6, 7, then from 7 you make a 17, and then P24. These are all made by the GAG gene. Now let's come to the third one, that is the Pol gene, and Pol gene is going to make RIP, means there are 3 enzymes that it makes. The R is going to stand for reverse transcriptase because it's an RNA virus. I will stand for integrase because after it comes in our body, it has to integrate with our DNA also. And protease is the one that is going to help in release of the virus, and I will show you the pathogenesis very soon. So I realized that the structural genes are 3, the envelope, then the GAG and the Pol. Envelope makes 3 things, 160, 120 and 41. GAG makes 6, 7, 17 and 24, and Pol makes RIP. After this comes a long list of non-structural genes, and their names are so weird. So now you know that okay, all the weird ones are non-structural. So we have TAT, NEF, REV, VIF, VPU, VPX, VPR and LTR. So let's know their basics, and you know these kind of tongue twisters will all be non-structural. Let's start with TAT. TAT stands for transcriptional transactivator. That is what it stands for. So what is it going to activate? Transcriptional. It is going to speed up the transcription process. Name is enough. Next we come out to NEF. That is going to be negative factor gene. Next we have REV. That is a regulator of the virus is required. Then for the infectivity we require viral infectivity factor. I mean, if you read their names, they are making sense. Now after this, there are 2 things that need to happen. Once the virus comes into our body, it has to enter into our cell. In order to enter into the cell or transport to the nucleus of our cell, it requires VPR. So can I say for transport, we have VPR, transportation into the nucleus. VPR will help it transport to a nucleus. On the other hand, once it has made all the things in all the new viral particles have been made and it's ready to be released, which is the molecule which is going to help it release from the nucleus is VPU and VPX. Please note, HIV-1 is going to have VPU and HIV-2 is going to have VPX. That's a difference. Till now, everything was common to both. So if you learn, VPU sounds like unloading. It has to come out of the nucleus. And VPX sounds like exit. It has to exit the nucleus. So now I know if when it has to go inside or penetrate or transport to the nucleus, it is going to use the VPR gene. But when it has to come out by unloading and by exiting, it is going to use VPU, VPX for HIV-1 and 2 respectively. Also, if I make the entire genome of HIV, you will notice that at the ends of the genome, there is something known as LTR. LTR is long terminal repeats. The name tells us that this is going to be at the terminal, and we know in biochemistry that it is going to have all the promoter and enhancer regions. All of these happen to be the non-structural proteins. So you've done the 3 structural, that is ENV, GAG and Pol, and then the rest of the story is non-structural. So that gets you ready for the pathogenesis. I have a virus over here, and you can identify it's HIV because it has 2 copies of RNA. It has something called GP120-41 written, which is only and only seen in HIV. So there's no doubt about it being HIV. The first step, of course, is going to be how HIV is going to come and attach. If you remember the first chapter of general virology, over there I taught you for any virus replication cycle, the attachment step is the most important and the most specific, most characteristic. So I'm going to take a separate slide and teach you attachment first, and then we'll come back and see what all has happened in the rest of the story. So now let's zoom into the attachment part. I can see the HIV here because I can see the labeling of GP120 and 41, and this of course must be the membrane of our body. So we all know that this GP41, if I write it, GP120 and GP41 comes and binds to which cells of our body? It is going to come and bind either to the CD4 T cells, or it can come and bind to the macrophages. How is it decided which HIV will bind to CD4 T cells, which will bind to macrophages? Right now you just need to know that okay, GP120 and 41 will come and they will bind to these CD4 cells. So that is known as receptor, that is the attachment. But one attachment for HIV is not enough. HIV is pretty deadly, so it requires 2 types of attachments. There is another attachment known as co-receptor binding. Co-receptor binding means that on top of this, for example, if this is the CD4 T cell, it will have another receptor called CXCR4. If this would have been a macrophage, it will have CCR5. So HIV also has to bind to this receptor, and then the binding will be complete. So what are these exactly? When I talk about CXCR4 or I talk about CCR5, you can see from their name. So CXCR4 is going to be on CD4 T cells, and that is why that HIV which will come and enter the CD4 T cells via what? Via CXCR4 will be known as the R4 type of HIV. On the other hand, CCR5 is going to be present on macrophages. So 5-phage, CCR5 is going to be present on macrophages, CXCR4 is going to be present on the CD4 T cells. Any HIV that is entering CXCR4 will be known as the R4 strain. Any HIV entering CCR5 on the phage or macrophage is going to be known as the R5 strain. So now if I come back, this was a CD4 T cell, so this must be having the CXCR4. This means this HIV that is binding to it is the R4 strain. But what exactly is this? In case you've forgotten pathology, CXC, CC, these are what? These are chemokines. So these co-receptors that you're talking about are the chemokine receptors. And ma'am, always and always some genetics will be involved everywhere. So just imagine some one lucky person is born without CCR5, means there is a CCR5 delta mutation that the person has. Now if the co-receptor is only not there, HIV will not be able to enter and bind. This means there is no HIV entry. I mean, what better thing could happen in this person's life, that the HIV is not able to enter the cells. So now coming back, the first step that was involving attachment had two attachments. One is the attachment of the main GP120 and 41 that comes and binds to either CD4 T cells or macrophage. Now depending on the cell that is there is a chemokine receptor also to which it has to bind. For CD4 T cells it is CXCR4, and for macrophage it is CCR5. Attachment is done. Once the cell has gotten attached to the HIV, now the HIV virus will be taken inside, and that is known as endocytosis. You can see how it has undergone endocytosis and then how it is finally present inside the cell. But now it had so many coverings and envelopes and all of that. The role is gone. GP120, 41 have done their role. Now it's time to leave. So now there's going to be shedding, and that is known as uncoating. Why are you doing that uncoating? Because you require the viral RNA. Those 2 copies of viral RNA are required, because now you will actually convert it and start forming new viral particles. So RNA, just imagine the virus is an RNA and I am a DNA. How will RNA and DNA get along? Of course not. So we will have to convert the RNA of the HIV into a DNA, and for that, what enzyme does it carry? HIV itself carries reverse transcriptase. Now the viral DNA is ready. So now it must enter into the cell. I just now told you to transport into the cell, it will require VPR for the transportation, and it has done that. Finally, moving forward, now the viral DNA is also inside and my DNA is also inside. So viral DNA and human being DNA will now fuse. That integration of the DNA and DNA, the viral DNA and host DNA, is done by which enzyme? Integrase. Remember, HIV had 3 enzymes, RIP. You have first used reverse transcriptase, R is done. The next is integrate, because that will help in integrating the DNA and DNA. And finally, once the integration has been done, the nucleus work is over. Now it's time that it takes an exit from the nucleus. And how does it unload or take an exit from the nucleus? So please note, in order to take an exit, please note these 2 things, because this is where students mess up. To exit from the nucleus, it will require VPU, that is HIV-1 virus, or it will require VPX for HIV-2, because I told you U for unloading and X for exit. So this is how it is going to exit from the nucleus. And now over here, you will see that there are lots and lots and lots of viral particle made. So finally comes step number 8, where there is a release of the entire virus from the cell. Release of the entire virus is carried out by the last enzyme, and that is known as protease. So when you learned the mnemonic RIP, you learned it in the order in which they are being used. The first is reverse transcriptase, then the second is going to be integrase, and the third is going to be the protease. Don't get confused on the release. If they say what helps in release from the nucleus into the cytoplasm, it is VPU and VPX. What helps in the release of the entire virus out of the cell is going to be the enzyme protease. And that wraps up the entire pathogenesis and gets you ready for things which you already know, and how is HIV transmitted. Now, we have always been taught that that blood transfusion is more than 90% incidence and sexual is only 0.1 to 1. But now you need to understand that this data goes way back to the time when blood transfusion was happening without testing the blood, and that is why so many people were having HIV and hepatitis. Now the blood is tested. I mean, it's a crime not to test blood before giving it to someone. So of course blood is going to be tested, and because of which this is nowhere close to anything that blood transfusion can cause. There are other ways now. Of course, there could be because of a needle stick injury, or it could be because of mother to child, because mother to child blood can go via the placenta. Needle stick injury can result in this. So just to give you, see, when we talk about needle stick injury, there is a difference between when they call it needle stick versus when they call it needle sharing, maybe for IV drug abuse, etc. So now, rather than learning the incidence, you need to understand what is the probability of having this. So the probability of having HIV following a needle stick injury is 1:300, and the probability of having HIV with needle sharing is much higher. It is 1 in 150, and this you need to read very carefully in the exam. They might not ask you ratios, but this is for your own understanding that while we keep emphasizing so much on needle stick injury because we are healthcare professionals, but what is even worse than that is needle sharing in IV drug abusers, because there the probability is 1:150. Now coming to the fact that nowadays blood transfusion is not the most common mode of spread. It is sexual, which was once upon a time considered rare. And sexual means it is going to be both heterosexual as well as homosexual. And under this, I've written both of these. Earlier, again, it was said that homosexual route was the most common because probably it was the homosexuals who were coming across out in the open. But it is very well known that heterosexual routes are still the most common. Now let's consider some unprotected sexual intercourse probabilities. If there's an unprotected receptor anal intercourse, that has a very high probability of contracting HIV, 1 in 30. Whereas unprotected vaginal intercourse has a 1 in 10,000 probability. So you might feel that these numbers are just 1 in so many, but ask that one person who gets it, that is going to be deadly. And you, of course, even without me teaching, you know the consequences of HIV. Now let's come back to the fact that we are healthcare professionals, and this is what we are most scared of, that is blood stick injury, which I've already taught you. You call it a needle stick injury. We in our lectures call it blood stick injury because then we can make it B, C, and I. Blood stick injury, and that would correlate hepatitis B for B over here, C will be for hepatitis C, and I will be for HIV. So blood stick injury will tell me HBV has a chance of 30% transmission, HCV 10 less, that is 3%, and further 10 in decimal you will make it HIV is 0.3%. So when you talk about blood stick injury, it is 30%, 3%, and 0.3% that you have to remember. Let's move forward to the toughest part. The next 10 to 15 minutes is where if you survive, then this chapter is easy for you. First, you need to understand the phases of HIV/AIDS. Then you need to understand the clinical features, the definitions, then the opportunistic infections, and finally the diagnosis. So it's not going to be an easy path, but you will get questions. In case you've read it from medicine, then I don't think there is much to offer beyond this point. You can continue with medicine notes, and if in case you've not read it there, then continue here. So now let's go forward and talk about the CDC classification that has been given for HIV, which divides it into CDC group 1, 2, and 3 and 4. So starting with the first one, this is said to be the initial infection. Now initial infection in many cases is said to be an acute infection also, which I will tell you. I'm just getting you familiar with the names. Thereafter in group 2, the patient suddenly becomes asymptomatic. I mean, first there are symptoms of acute infection and then the patient becomes asymptomatic, means he slept off. There is a clinical latency, but that is just the silence before the storm, because thereafter comes group 3 where there is persistent glandular lymphadenopathy, and thereafter group 4 is what is ARC, that is AIDS related complex. So when you're talking about these 4 groups, let me go forward and study it well with the help of this graph. Now in this graph, obviously the x-axis has all the years and basically the timeline. The y-axis, on one side they are trying to denote the CD4 count. So the CD4 count is going to be denoted by the blue color line over here, and the red color line is on the other hand showing us the HIV copies, that is the HIV RNA. So if you go for a normal person, what do you expect the CD4 count to be? Well above 1100 to 1200. So that is the normal CD4 count, and obviously you expect that HIV copies would be 0 in any normal individual. So that is where we are starting from. Now once a person contracts HIV, you would notice that the incubation period for HIV is said to be 3 to 6 weeks. Now following that, I can see that the HIV virus, the red color line, the HIV RNA has started to rise in the blood. Now if the HIV RNA is rising, we know it goes and attacks the CD4 T cells, so automatically automatically the CD4 count will start falling. So you can see there comes a time when the HIV RNA has started to rise and there is a decrease that you notice over here in the CD4 count, and this is exactly what has happened. So as soon as the primary infection occurs, there is going to be, that is what we called as grade 1 or the phase 1, that was the acute infection. This is acute HIV syndrome. Now this patient has typical features of infectious mononucleosis, and so many people right now in this phase can never ever detect it as HIV because they keep saying it is IMN, infectious mononucleosis like. Because look at this, the patient is going to have fever and weight loss. Along with that, there is going to be lymphadenopathy, just like how it happens in infectious mononucleosis, which was caused by Epstein-Barr virus, so also called glandular fever. So I told you there's going to be fever and all the glands are enlarged, like lymph nodes are enlarged, like for example hepatosplenomegaly is there. Then also there is sore throat. Patient might have skin rash, nausea, vomiting, muscle aches and pains, maybe some headaches. So I realize overall it's a very non-specific infectious mononucleosis like condition. It has happened because the HIV copies have risen and the CD4 count has fallen down. But now comes a time of what we call as seroconversion. Seroconversion means that there is a moment where the body tries to fight back. Now there are a lot of hypotheses of how this happens. So you will see that for a very temporary duration, there is going to be an increase in the CD4 count. So they are trying to fight back and they are trying to replenish themselves. And if they will fight, of course, the HIV copies will fall down. So you can very well see that in the first stage, the HIV was increasing and our body was crippling. Now what has happened, our body has decided to fight back, and after this the HIV copies will of course start falling, because of which the patient now goes into stage 2, which is known as clinical latency. I mean, if your immune cells start fighting for you, then who can harm you? You will stop showing the symptoms. That is clinical latency. That doesn't mean microbiological latency. So at this stage, if you do testing for the person, he will still come out to be HIV positive. This is only that clinically he has stopped showing you features. So the phase 1 or group 1 was initial infection, acute infection, which we've done. Then group 2 is clinical latency, where the patient is clinically asymptomatic but not microbiological latency. And thereafter, when the patient starts becoming symptomatic, and you will notice as the disease is going forward once again, and this could happen after many years, the patient is going to once again start showing the clinical symptoms, and that could be a case of PGL. What is PGL? Persistent generalized lymphadenopathy, which tells me that of course there is going to be lymph nodes that are going to be there. Generalized word tells me that there are going to be 2 or more than 2 non-contiguous extrainguinal sites involved. What does that mean? Firstly, they're talking about sites other than the inguinal. Then they're talking about non-contiguous. Non-contiguous means that they are not in continuity with each other. It's not that the 2 lymph nodes are present both in cervical, or both of them are in inguinal, or both of them are in axillary. So they should be 2 separate sites, and there should be 2 or more than 2 such lymph nodes. But then I've understood that, okay, that's why they called it generalized, because they should not be as in the same site, they should be at different sites. And persistent will tell me finally that this is going to last or should be there since at least 3 months. So please note, there is enlarged lymph nodes which are at 2 or more than 2 non-contiguous sites which are non-inguinal or extrainguinal, and finally this is for equal to more than 3 months. So that is known as PGL, and once that phase or group is done, thereafter the patient goes into full-blown AIDS, which is known as the AIDS-related complex, and that AIDS-related complex is usually seeing that full-blown AIDS is defined when CD4 count is going to fall below 200. So if you look very carefully, by the time I have started dividing it as AIDS-related complex, you can only do that when the CD4 count has fallen below 200. That is the definition. So the 4 stages are pretty much clear to you, but now you also need to understand that as your CD4 count in this patient was dropping from 600, 500, 400, 300 and all, the patient must have become prone to a lot of opportunistic infections. And I think this is the most troublesome question that you get in the exam. We'll try to make it a little simple in comparison to how it's given in the books. Number 1, when the CD4 count reaches 600, 600 is for swollen lymph nodes. That is going to be lymphadenopathy. So 600 for swollen lymph nodes. Thereafter, when it coming nearly about 500, it can cause herpes zoster virus. So please remember, at 500 there can be herpes zoster virus. Now below 500 is how you get the question, and there is a very famous sarcoma that occurs, that is Kaposi sarcoma. Although the textbook says that Kaposi sarcoma can occur at any count, typically it also occurs more as you go lower down, that is below 200. But the question was asked that what is the count after which Kaposi sarcoma can occur? It it can occur anytime below 500 count, or anytime below 500 would mean a 400. Now let's come to 300. That is going to be seen, that would result in oral hairy leukoplakia, which is caused by Epstein-Barr virus, or it can also result in pulmonary tuberculosis. Finally comes less than 200, which you already remember. There was one fungus which is known as PCP, that is Pneumocystis carinii pneumonia, which always tends to occur below 200. This you studied in mycology. Apart from that, these patients are also going to have MCM. I mean, that's just a way of learning. Below 200 is PCP, Pneumocystis carinii pneumonia. But other than that, there is going to be miliary TB. So if they just ask you TB that had started occurring at around 300, but below 200, miliary TB will occur. Then the next thing is going to be mucocutaneous herpes can occur. Then Candida infection, which is a fungal infection. And then another C, that is Cryptosporidium, diarrhea infection can occur. So if you remember, Cryptosporidium used to cause HIV positive patient with diarrhea was Cryptosporidium. So repeating, Pneumocystis carinii pneumonia. Along with that, there is going to be miliary TB, mucocutaneous herpes, Candida, as well as Cryptosporidium. That was less than 200. Now let's go further down. Less than 100, you will see all the organisms that have straight away gone to the brain. So when I talk about toxoplasmosis, cerebral toxoplasmosis is what I'm talking about. Cryptococcus causes what? It's a fungus, causes meningitis. What lymphoma? Brain lymphoma. Then HIV-associated dementia or PMLE, which is progressive multifocal leukoencephalopathy. All brain-related things are less than 100 CD4 count. And finally, less than 50 are just MAC and CMV. How simple? MAC is the Mycobacterium avium complex, which is atypical mycobacteria, and CMV causes CMV retinitis. So repeating once again, just for your revision, at nearly 600, it is swollen Suja Hua lymph nodes, that is lymphadenopathy. 500 is herpes zoster, if you can remember, but below 500, Kaposi is very important. At 300, TB is important. Less than 200, PCP and MCM, Pneumocystis carinii pneumonia, and apart from that, Candida, Cryptococcus, mucocutaneous herpes, as well as miliary TB. Coming to less than 100, everything to do with the brain, and less than 50, where I expect a question, CMV retinitis and Mycobacterium avium complex. Now, having done this, we come down to the next two things. So there is a definition of AIDS which has been defined by the WHO, which says that there should be at least two major signs along with a combination of at least one minor. So they are saying that there should be at least two major signs, at least, with a combination of at least one minor sign. So what is the major sign? Of course, this is a patient who's coming to you with HIV. So fever will be for more than 1 month. Along with that, you know, HIV is known as the Slim's disease because patient loses a lot of weight. So weight loss is more than 10% of the body weight. That is significant weight loss. And that is also attributed to the diarrhea which is occurring since over 1 month. So fever more than 1 month, diarrhea more than 1 month, and so much so that the weight loss has happened more than 10% body weight. These are three major criteria. Now everything else is going to come under minor criteria like cough for more than 1 month. That could have been because of HIV or it could have been because of an opportunistic infection like TB. Further, there could be some disseminated herpes infection or there could be generalized lymphadenopathy. Please, when I say 1 month, 1 month, 1 month, they ask you which of these 1 month criteria are major and minor. So fever and diarrhea are major, cough is going to be minor. Repeating, out of the major criteria, at least two should be present, and out of the minor criteria, at least one should be present. This combination would be the AIDS definition by WHO. But then there were some AIDS definitions which were given by CDC also, and of course that's not easy, but these are all the infections which come under the AIDS definition. So I'll start off with, I've written all the C's. I've tried my best to simplify this as much as we can, all the C's together, all the P's together, and then the miscellaneous. When I start with Candida, they say candidal infection of mostly the upper body. That is going to be the trachea, the esophagus, and the bronchus. So this does not include the vulvovaginal candidiasis, for example. Next, coming to Cryptococcus, we know it causes meningitis. Next, Cryptosporidium parvum, we know that causes chronic diarrhea more than 1 month in HIV positive person. CMV colitis, of course, that is going to result in serpiginous ulcers as we have studied. Cerebral toxoplasmosis, known for causing fever and causing seizures in the brain, of course, undoubtedly cerebral. And I always used to teach you that toxoplasma goes and involves the brain parenchyma. That is where it causes calcification also. So seizures would occur. CNS lymphoma, most commonly in HIV, is DLBCL. Then comes PMLE, which is progressive multifocal leukoencephalopathy, and that is associated with a virus that is known as JC virus. Thereafter, we have Pneumocystis carinii pneumonia, which is possible only when the CD4 count falls less than 200. So if you noticed, all the infections that you have read with C up till now have come over here. then in P you had PMLE and PCP, and then you have 3 miscellaneous infections like herpes simplex virus. What kind of ulcers does that find? Classical punched out ulcers. Thereafter, Kaposi sarcoma, which is associated with human herpes virus 8, and lastly we have MAC, that is Mycobacterium avium complex. So these are all the infections, all the C's, all the P's, and then you have 3 more to learn: HSV, HHV8 and MAC. HSV, HHV8, Kaposi sarcoma and MAC. But now they ask you a question, what are out of all of these the AIDS defining malignancies? I mean, some of them I can see clearly. I can see a Kaposi sarcoma written here. I can see a CNS lymphoma also written here. So anything that I'm missing out on, I am missing out on something called invasive carcinoma cervix, because that could be associated with human papilloma virus, right? So human papilloma virus, carcinoma cervix, Kaposi sarcoma due to HHV8, and lymphomas that you have. So what all lymphomas are we talking about? That could be a CNS lymphoma, which all of you are saying is DLBCL. Then there could be a Burkitt's lymphoma, or it could also be an immunoblastic lymphoma, and that's the AIDS defining malignancy. So many things done. You've done the definitions. Why don't we end up doing some one-liners which will give us more clarity? If I ask you question 1, what is the most common opportunistic infection that you see? Is, of course, in our country has to be pulmonary TB. Question number 2, what is the most common fungal infection that they would see? And the answer would be Candida. Question number 3, what is the most common space occupying lesion? Of course, that's going to be a CNS lymphoma. Space occupying lesions are set for the brain, and the CNS lymphoma that we are dealing with over here is, I'll answer it in the next question, that is going to be DLBCL. Now we are left with one question in between, most common glomerulonephritis. If you remember, I've taught you this in pathology with a mnemonic called HRs, which you have studied under FSGS. Yes, FSGS has a variety called HIVAN. HIVAN is HIV associated nephropathy. So FSGS is the most common glomerulonephritis seen in HIV. Now coming to the most common hepatitis that you see in HIV is going to be, most common answer is always hepatitis B. Probably 2 questions which you don't know an answer to. What is the most common skin symptom? A lot of controversy, but best answer would be seborrheic dermatitis. And the most common endocrine system would be lipid related disorder, that is going to be lipodystrophy. All your one-liners of all the subjects are done. Now I want to ask you a practical question. You have a patient of HIV and you would start him on antiretroviral therapy, but at that time he also has opportunistic infection, most common being what? Most common is TB. So if the person comes to you with HIV and TB, what do you start treatment with first? Would you first want to start treatment of HIV with antiretroviral therapy, or start the treatment of TB with anti-tubercular therapy? I mean, common sense as a layman would tell you that HIV is a more severe disease, so you would want to give antiretroviral therapy first to save the patient. TB can still be treated after a few weeks, but it's actually the other way around. We first start the patient on anti-tubercular therapy, that is ATT, and 2 weeks later, then we start antiretroviral therapy. And why is this so? See, in case you would have given antiretroviral therapy first and you would have started killing the HIV, the patient's immune system would have suddenly risen. Improvement would have been seen. When the immune system would have risen, immunity would have found that, oh, there's a bacteria called TB roaming around. Now the immune system will get so hyperactive and so exaggerated that it will start mounting a very, very strong response. I mean, that is good, because then TB will be killed, but the immune response is so strong that it will start damaging our own tissues. That syndrome is known as IRIS, that is immune reconstitution, because you have, by giving ART, you have basically revived the immunity of the person. So there is an immune reconstitution which has resulted in an inflammatory syndrome and gone and caused so much of inflammation in the body that the tissues are getting damaged. You don't want IRIS to occur. That is why first you get control of TB by giving ATT, and 2 weeks later, now once the bacilli are in control, you can start with antiretroviral therapy after 2 weeks. Now let's move forward. Another thing, because I'm talking about TB, I'm talking about pulmonary infection. So in HIV, what are the different pulmonary infections that could happen? I mean, you already know when the CD4 count is less than 500, I told you that there could be TB, which is the most common, and there could be streptococcus pneumonia also. Versus when the CD4 count is less than 200, then the pneumonia is going to be pneumocystis carinii pneumonia. So there is one way of dividing it, and that is going to be with the CD4 count. Less than 500 you will have pneumococcus and TB, and less than 200 you will think of PCP. But CD4 is not the only criteria by which you will diagnose pneumonia. You will also look at the radiological findings. Now, while we know that streptococcus pneumoniae results in entire lobe consolidation, so if I had to draw it out, this is how it would look like. An entire lobe would be involved, that is lobar consolidation of streptococcus pneumoniae. On the other hand, when I'm talking about TB, this is is without a say we know that there is going to be a hazy or a snowstorm appearance that you see on radiology. On the other hand, when I talk about pneumocystis carinii pneumonia, it is going to be perihilar opacities that you get to notice. So now, for example, if they say that the CD4 count has gone less than 200, and along with that, radiology is showing you the lobe consolidation. So what do I mark? Please note that when I say that pneumococcus occurs less than 500, so obviously less than 500 would also include one much lesser, less than 200 as well. So go for the radiology, give importance to what is seen with your eyes inside the patient, which carries more importance than just a CD4 number. So please note, you will mark whether it's lobe consolidation with CD4 less than 200, I will still mark pneumococcus because radiology is going to be more significant. So repeating, pneumococcus shows lobe consolidation, TB shows snowstorm or hazy pattern, which is said to be the hazy appearance, and finally the pneumocystis shows you perihilar opacities. Now let's go forward and talk about the diagnosis. Obviously we are going to do a CD4 count, that goes without a say. You are usually asked what is the sensitive test which is used for screening, and for screening we are using the 4th generation ELISA. I'll keep coming back to this particular chart, but please note that screening assays, you don't have to learn all of them before you start feeling a little complex. So there are 5 generations of ELISA. Now even a 5th generation has come up, but still what the textbooks mention as the screening assay most significant for HIV is the 4th generation, where you can see it is going to detect the P24 antigen also, it is going to detect the antibodies also, and this is a very sensitive test, and hence they are saying that the 4th generation ELISA is the best. But what is going to be confirmatory, of course, is going to be Western blot. There are many other methods. Again, if I want to show you just a chart for not you to learn but just to go through, for confirmation we have many tests like line immunoassays, dot immunoassays, but they say that Western blot in our country is said to be very specific, and this is the one that is said to be confirmatory. Apart from that, we can also go in for PCR, RNA virus, so RT-PCR is done. But for pediatric population, now what if there is a child who is born to a mother with HIV? Pediatric population, so now common sense tells me that when I'm trying to do a PCR for an RNA virus, in simple words, I'm trying to do an RNA PCR, right? Because then I will take the RNA with reverse transcriptase, I will convert it into a DNA, and then I am going to go ahead and put the cycle. But for pediatric population, we try to go for a DNA PCR because that is shown to give a better result. Keep this question in mind, especially in peds, it could be asked. Now what I want to go into detail of is, I've already told you the screening test is going to be ELISA, 4th generation. The confirmation test is going to be Western blot. So let me actually tell you what this Western blot is all about. This is a paper strip method. You can very well see, and if you want to read it from the chart, there are nitrocellulose strips that are present, and on those there are many different viral proteins there in the form of bands. Whatever you have read, see it. Now what is this? This is a nitrocellulose strips in which there are many viral proteins. You can see all those GPP markers over there, and how are they going to come positive? They are going to come in the form of bands. So now how many bands should I see to be able to call it positive? So over here I've got the textbook information, here I've got a real Western blot. Again, there are 2 classifications given by WHO and CDC. WHO says that antibodies against 2 envelope bands. You tell me, what were the envelope bands? The overall number was GP160, and when we split it, it was GP120 and GP41. So out of these 3, they are saying any 2 envelope bands that are present, and after that, if other GAG and POL genes like P6, 7, 17, 24, and then those enzymes, RIP, if they are present or not, that is supplementary. But what has to be there are at least 2 envelope bands, and it's positive. CDC pretty much says the same thing. It has taken 4 proteins. It says the same GP160, GP120, and GP41. The same 3 have been taken, but CDC says I also want to take into account the capsid protein, that is P24, and now out of these 4, I want that at least 2 should be present. So WHO had kept the 3 envelope proteins and wanted at least 2 out of those. CDC has kept 4 proteins, 3 are enveloped, 1 is P24, and out of those 4, CDC wants any 2 to be present. So either ways, both of them want at least 2 bands to come up. Now let me start seeing this. Over here, I have used a reactive control. So control means that this is the control line, it has to come. Control line means that the test has been done properly, so that is fine. After that, let's assume I take the first thing. First, I will see the control line. Patient 1 control line has come, the test has been done properly. If I start counting, I have to count the envelope proteins. Let's assume we are going in for the WHO definition, GP160, GP120, and GP41. So out of these, of course, I can't even see bands because it is so strongly positive that everything has come positive. All 3 have come positive. Apart from that, even P24 has come positive. So when everything is positive, this is a clear-cut strong count positive. In other words, if I want to show you diagrammatic, GP160 is positive, GP120 is positive, GP41 is positive. For that matter, P24 is also positive. This is a strong reactive. Let's look at the patient number 2. Control is there. This means the test is valid. Over here, GP160 and 120 are coming. GP41 is coming. GP24 is coming. Yes, this is also positive, but I don't see that kind of a positivity which I'm seeing in the first case. Now, if you look over here, all the envelope proteins are coming, but look at this case. GP160 and 120 are coming, but there is no GP41. But then WHO said that out of the 3 envelope proteins, if any 2 are also present, the work is going, plus P24 is also there, so I will still consider it as positive. Now let's go to this. Is this patient even worthy of being read as a report? No, because I don't see the control line, and that is very, very essential. If your control line is not there, don't read the report. Here the control line is read, here I will read the report. None of them have come positive. This means this person is negative for HIV. So please note, for WHO, 2 out of 3 envelope proteins should be there. CDC says 2 out of the 4 have to be there. Out of this, if I ask you, antibodies appear earliest for antibodies earliest appear for which protein, you might want to answer P24, as all of you have read in many textbooks, but antibodies is what I'm asking. Antibodies appear first to GP41, that's the envelope protein, then antibodies appear to P24 in the body, and then to GP120. So I have sandwiched the P24 in between the 2 envelope proteins. This is a question, you will see it in your Q bank, subject test, grand test. Which is the protein against which first antibody is formed and seen is going to be GP41. Also, many of you would have read that, no ma'am, I had read P24 comes, but what you had read was a P24 antigen. I am talking about antibodies over here. So let me solve that query also. Let's assume that someone as a healthcare worker has had a needle prick injury. Now on a needle prick injury, everyone has taught you that, oh, go get your P24 antigen done. But you need to understand that even before P24 antigen, something is going to rise in the blood, and that is the HIV RNA. So the best and the earliest test that should be done following any exposure is going to be HIV RNA, and if that is not possible, thereafter it is going to be P24 antigen that is going to be tested. Now if I come back, there is one small NACO guideline also that has been given. Number 1, they say that you have to do the testing for, or immunoassay or ELISA testing, which is a screening test, right, for HIV 1 and 2, and if that comes out to be negative, this means the patient is negative. Along with that, if the patient comes out to be positive, now this is a screening test positive, and that is a common test for both HIV 1 and 2. So you are now going to go ahead and classify whether it is 1, 2 or both. So now you're going to do the differentiation immunoassay. On differentiation immunoassay, if you got only HIV 1 positive, then you will say, okay, HIV 1 antibodies detected, this is HIV 1. If HIV 2 antibodies have been detected, you will say this is HIV 2. If both have been detected in a very unfortunate situation, then you will say positive for both. However, if none have been detected or it is indeterminate, you are in a dilemma, because patient has one report in his hand which is reading positive and the second report in his hand which is reading negative, and then he has gone into a full panic attack that am I positive or negative. So you will have to do something for confirmation and settling this dilemma. So you will do a nucleic acid test. Of course, you will have to do a confirmatory nucleic acid test. I mean, if that comes out to be negative, then you're like, okay, that screening test was just a false positive, you are negative. And if that comes out to be positive, then it is a clear-cut positive. That's just a basic protocol of what we follow. However, the NACO guidelines do vary as per the different groups which you have to study in medicine. So you can never take a skip of medicine and micro and path. HIV in every subject is going to have its own set of importance. Now, finally, I'm done with all of this, which gets me to the fact that HIV was one of the retroviruses, and there's another one which was falling under the Oncoviridae family called HTLV1 and 2. Now, what is HTLV full form? It is a human T-cell leukemia lymphoma virus. So I have understood it's going to occur in humans. It is going to be a virus. It is going to cause blood cancers, leukemia lymphomas, and of the variety T cells. So what do? They come, and how do they come in our body? They come just like HIV. They come from different kind of blood and body secretions. So for example, even breast milk can transmit HTLV1. Once they come into the body, what are they going to cause? They carry with it something called as the TAX gene, and this comes in number 1 causes tropical spastic paraparesis. That is one disease, but that is non-cancerous. You were saying, ma'am, HTLV comes under Oncoviridae family. So one is tropical spastic paraparesis, which is non-cancerous. The cancer that it causes is in its name itself. It is going to cause T-cell leukemia and lymphoma. The name tells you. So it is going to cause T-cell leukemia lymphoma in adults, and that is why ATLL stands for adult T-cell leukemia and lymphoma. Via which gene does it cause all of this? TAX gene. So look at the entire story of TTT. HTLV1, which causes T cell disorders, is going to act via TAX gene. Number one, it causes tropical spastic paraparesis. Number two, it causes T cell leukemia lymphoma. Finally, let's look at a case of T cell leukemia lymphoma under the microscope, and I would notice the beautiful clover leaf cells, which means that the nuclei are going to look like these flower, probably something like a flower or a leaf. So that clover leaf nucleus is very characteristically seen in case of HTLV, and a very, very famous question. Of course, with that, the entire Retroviridae family comes to an end. A quick question says, which of the following are minor signs under WHO AIDS definition, except, see, cough more than 1 month, this is definitely a minor sign. Herpes zoster is a minor sign. Some kind of dermatitis, pruritus, generalized, yes, minor sign. But chronic diarrhea for more than 1 month, remember I told you, if there is fever for more than 1 month, with diarrhea for more than 1 month, and that diarrhea has resulted in more than 10% significant body weight loss, that is going to be major criteria. So the answer over here is settled. Coming to the next question is, which of the following confirmatory assays for HIV infection shows specific banding pattern indicative of HIV infection? So please note that is going to be Western blot. I've told you it was showing you those bands. One question that I've not included because it is very obvious. They will always give you the history of a nursing officer or some healthcare professional who has just gone a needle prick injury. Following that needle prick injury, what is the